esteemed faculty members, and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Pinnacle News Series, episode 24, in association with Aligarh, Hapur, Darbhanga, Sagar, and Kanchipuram OBGYN societies. So let us start the webinar with Saraswati Vandana.
आप लोगों करिए जी क्रिकेट
It's my privilege to introduce the moderator of this webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant obstetrician and gynecologist from Salem, National Coordinator of Midlife Management Committee, FOXY. I welcome you, ma'am, and I hand over the session to you.
Thank you very much, Sahiti. It is my pleasure and privilege to welcome you all to this Pinnacle News webinar series. Today, which is in association with Aligarh, Hapur, Darbhanga, Sagar, and Kanchipuram societies. A hearty welcome to one and all. This webinar series is brought to us by Professor Dr. Sampath Kumari ma'am. Can I have ma'am CV, please? Ma'am is a professor and HOD of Sri Muthukumaran Medical College and Research Institute in Chennai, past Vice President of FOXY. She is the Senate member of Tamil Nadu Dr. MGR Medical University and also the National Corresponding Editor of JOGI. She is the founder secretary of Tamil Nadu Federation of Obstetrics and Obstetricians and Gynecologists. She is currently the president of OXY and she is the retired deputy director of Institute of Obstetrics and Gynecology at Madras Medical College at Chennai. President Board of Studies for Tamil Nadu Dr. MGR Medical University. She is a past chairperson of FOXY Adolescent Health Committee. She received the first ICOG Distinguished General Council Member Award. She's the chairperson of Women's Wing of Indian Medical Association, Chennai South, and also she's received various awards, among which are the IMA National President's Award and the Tamil Nadu State Branch Award. Over to you for the welcome address, ma'am.
Yes, thank you, Dr. Madhumita. See, I welcome all the president and secretaries of the societies, Aligarh, Hapur, and Kanchipuram, remaining two societies. What is the other, ma? Madhumita?
Ma'am, Aligarh, Hapur, Darbhanga, Sagar, Kanchipuram.
Darbhanga, Sagar, and Kanchipuram societies. See, this is the webinar which is done from one societies or two societies from north, east, west, and south. That is the reason it is called as Pinnacle News. So today we have two sessions. One session being the prediction or screening of preeclampsia. The other one is being the PPH. We have Dr. Poonam Dixit for the talk and the next followed by the PPH panel discussions. So first I welcome Dr. Jyoti. She is the president of Sagar Society. Dr. Jyoti.
Namaskar, madam. It's a pleasure to be with you on a webinar. It's our pleasure that our society is joining with you.
Dr. Jyoti is the president of Saga branch, ex-regional director, graduated from JLN Medical College and presented various papers and won many trophies, a recipient of Dr. D.K. Tank Trophy and Durusha Award. Dr. Jyoti, few words.
Yes, ma'am. The topics that you have selected are very meticulous because these are the two major killers and they are responsible for maternal deaths. So, if we master them and develop the skills to take care of the patients presenting with these two problems, I think we'll have the war won. At least 50% of the war would be over. Thank you for including me, ma'am.
Thank you, Dr. Jyoti. I think Dr. Tamkin is there, the Taligar Society president. Sahiti, Dr. Tamkin has joined. Okay, whenever she is joining, we can include. Thank you, Dr. Jyoti.
Yes, ma'am.
We'll start with the scientific session. Before starting the scientific section, I am Dr. Sampath Kumari from Chennai. I am contesting for Foxy President. The election year is now the 2026. The election timing is August 1 to 10. All of you, please vote and make your society people to vote for me.
Sure, ma'am. All the best to you.
Aditi,
After
ma'am,
35
slide,
years
election
from
slide.
South, we are contesting. Thank you so much. We will go with the scientific session. Yes, Madhumita.
Yes, ma'am.
Poonam Dixit CV Poduma Sahiti.
Dr.
Dr.
Poonam,
Poonam.
ma'am, you'll introduce, ma'am, Dr. Poonam. Sampath, ma'am, you'll introduce Dr. Poonam Dixit.
Dr. Poonam. Dr. Poonam is from Patna. She is an RCOG member and she has lot of credits to her, but she didn't send her CV, I think.
I
So
have
Dr. Poonam,
it
we will
in my presentation. I just
Yes.
show
Yes, ma'am,
it.
please share, ma'am.
Okay,
Please share.
Dr.
And
Poonam,
before it
stage is yours.
opens, I'm contesting for Vaginal Surgery Committee
Oh, that's great.
chairperson this year. So need
Okay.
your help and support.
Yes, ma'am.
Yeah.
All the best, ma'am. Best wishes.
Thank you. Can you see my slides?
Yes, yes, ma'am. Yes, ma'am. Just go on full screen, ma'am.
Yeah. So at the outset, I want to thank Professor Sampath and best wishes for your election. And a big welcome to all the presidents and secretaries. And this year, as I said, I'm going to contest for vaginal surgery. I do, basically, I take pride in being a clinician. At the moment, I'm member like the vaginal surgery committee, and also I'm president SOPSI Bihar and Jharkhand chapter. I have conducted many live surgical workshops of vaginal hysterectomy in medical colleges and in Foxy conferences and many other public hospitals. I'm also an MRCOG examiner. So anything which improves clinical outcome and service to the, and one special interest I have is making the, bridging the gap between what we practice and what the public perceives. So moving on, thank you very much for giving me this topic, which I really love. So we all know preeclampsia is a multi-system syndrome developing during the second half of pregnancy, and it is characterized by hypertension and proteinuria, or in absence of proteinuria, now organ dysfunction has also been included in the definition. And that would, how it manifests, we'll come to it later. Why it's moving on its own. So preeclampsia develops in 2 to 5% of pregnancies, as we all know. And in 1/3, the delivery will occur less than 37 weeks, and in 2/3 after 37 weeks. And it's a major cause of maternal mortality and morbidity. And roughly, as we speak, so 50,000 deaths worldwide. And if you look at the new mortality, that goes in lakhs. So the figure of 5 is important and is phenomenal. So not only the mortality, but if you look at the morbidity, we are aware of the near misses cases we get in mothers. And when we talk of parental morbidity, which is related to FGR, induced preterm, and then again we have stillbirths, So 25% of all stillbirths. So look at the magnitude of the problem. So 25% of the problems are due to preeclampsia, and 15% of FGR babies are due to preeclampsia. So we all agree it is a condition worth preventing. And when we talk about these risks, they are much, much severe in early onset preeclampsia. Briefly looking at the pathophysiology, which we are all aware. So what happens is there is impaired trophoblastic invasion of the maternal spiral arteries. There is placental hypoxia and release of trophoblast factors into the maternal circulation. This leads to platelet and endothelial cell activation and damage. And that is how we get all the symptoms of preeclampsia, starting from hypertension, proteinuria, and organ dysfunction. Just illustrating a bit more, if you look at the arterial system of the uterus, so we have uterine, arcuate, radial, basal, and spiral. And what happens is there is these vessels opened up when the trophoblast invades, and all the arteries, they turn into big, like lakes, and that is how the uterus is getting ready for the fetus. But in preeclampsia, due to the factors I just discussed, there is lack of the second wave of trophoblastic invasion, and that is where we need to pick up the patients, and we need to prevent the this disease with serious mortality and morbidity. So it has been a focus of research and clinical practice, and traditionally people were screening on age, weight, race, parity, etc. And meta-analysis did show that the use of aspirin decreased the incidence by 10% if we screen by these methods. Aspirin after 16 weeks did not reduce the incidence, and the dose was equally important. So what dose to give? We'll discuss that. I don't know why it moves. So this is the famous aspirin trial, which you all must be aware of. So this is a combined multi-market screening and randomized patient treatment with aspirin for evidence-based preeclampsia prevention. A multi-center trial, which it was headed at King's. I think Professor Leona Poon, Leona was heading that research, and it involved 27,000 pregnancies, and they were screened at 11 to 13 weeks of gestation, and those at high risk were given 150 milligram of aspirin at night. So do remember the dose and the timing. And use of aspirin was associated with 62% reduction in preterm PE and 82% reduction in preeclampsia more than 34 weeks. So this is phenomenal that we are trying to reduce the preterm preeclampsia. So what are the included? Mean arterial blood pressure, which should be measured by validated automated devices. Mercury sphygmomanometer should not be used. Arms should be supported at the level of heart. And after resting for 5 minutes, BP should be measured in both arms. And total 4 readings are taken, so the MAP is calculated properly. How do we measure uterine artery PI? Transabdominal or transvaginal. In first trimester, first we get a sagittal section of the uterus. And we locate the uterine artery at the level of internal os. What I do these cases myself. So the common error which happens, I'll just briefly talk, that we tend to measure the arcuate. So one parameter to distinguish is your peak systolic velocity should be more than 60 centimeters. That is when you are measuring the uterine artery. Both right and left should be measured. And whichever side has got placenta, there the PI will be less. So we combine both the arteries and give it to the lab, so the risk is calculated. So this is the figure to show at the level of uterine artery, we pick up at the level of internal os, we pick up the uterine artery. This is figure to show what you see on the A is the figure where it is normal. On your right, you see the PI is raised. Raised PI means less diastolic flow and less blood supply to the uterus. So in normal pregnancy, UTPI is low, reflecting low impedance to flow as spiral arteries are transformed into low resistance channels, which I just discussed. But where there is impaired placenta, placentation, and at high risk of developing P, the UTPI is high. Another marker which is checked is placental growth factor, and PIGF is a potent angiogenic function. In high risk group, levels are reduced. And there are other markers also which are not good in first trimester, such as SFLT1, called in abbreviated form, but they can be measured in 20 weeks, but at 32 weeks, but that is not something very popular. So let us look at, all of you do know that the pre-eclampsia screening has been combined with the first trimester screening. So already we have Kappa-A and PIGF, and we are adding the maternal characteristics and blood pressure and uterine RT-PI. So if you look at this graph carefully, you see the PAP-A in the normal pregnancy. In early preeclampsia, the moms are reduced. In late PA, reduced, but not as much as early. And in gestational hypertension, they are a little bit different. So hence, not much role in predicting gestational hypertension. On the figure B is showing PIGF. And this again, you see the normal, early and late, and all the moms. This is a very important figure to remember. And whenever you see the lab report, always read the moms. This is just to show that if we screen just by maternal factors, we are picking up only 58%. If we combine maternal factors with MAP, 65%. So as you go on adding, the sensitivity of your screening test increases, and right down you see the MAP, UTPI, and PLGF, your sensitivity has gone up to 90% as far as prediction of early onset preeclampsia is concerned. A lot of women do not come in the first trimester. We can still screen at 20 to 24 weeks by combining MAP, ATPI, PIGF. SFT, as I said, can be used. If we have nothing, at least uterine artery should be done, and we have cutoff PI for every trimester. If it is high, then we can treat them as if at least we can offer them vigilant monitoring. So this is just to say that how important it is that we screen and that we have a very sensitive test, which sort of almost detects 100% of early onset preeclampsia. We will be treating few patients who will not develop, but then it is worth treating because treatment is not very expensive. So what are the barriers? We all know that not every woman gets the screening. One is patients are not coming that early. Even if I counsel one of my patients, she had severe early onset preeclampsia in first pregnancy. We delivered at 27 weeks. It all ended well. I told her, before you conceive, you should meet me. But she came to me at 16 weeks. So this is this I'm talking about private sector, the patients who are sort of well educated. And then we have large chunk of patients whose education level is much less. So this is a big barrier in our society. And to overcome that, I think we have to take a lot of strategic decisions so that every woman gets this screening. So cost, training of staff, and we have to... People say that uterine RT-PI measuring is very easy. It is easy if you know how to do it, and it should be correctly done. So if we don't, and then not to talk about the cost, everywhere people talk about the cost. The costs have come down markedly because now, earlier I was, in my own, in last decade, the PIGF is being done for a very little price now. So if we cannot do the serum markers, we can at least do the maternal risk factors and uterine RT-PI. And how do we get trained? There are many FOXY and ICOG training centers, basic and advanced. I also run a FOXY ultrasound training centers. And then Fetal Medicine Foundation, which is free, and it has excellent education. And those of you who are doing fetal medicine, a lot of you are aware that our all ultrasound trainings they get certified from FMF, and that is online and you just upload your images, and training is available even for uterine artery. ISIOG is another society which has got it is International Society of Ultrasound Obs and Gynae. I was associated with it as a member advisory committee. So that also has very good resources like an online basic training, which is structured for a resource country. And these are invaluable sort of tools, I can say, for every practicing obstetricians to improve their clinical outcome. So just to conclude that screening and prevention is the desired aim of our antenatal care for any medical condition which has such a serious outcome. We all know that ASPRI trial has shown the advantages. There is no doubt about it. And a lot of people say that, oh, why do all this? Just give 150 aspirin to everybody. But then rationale behind it is that if you tell the patient that you belong to this group, then the compliance is better. And this dose has to be given at night time, and the dose has to be correct. Cost I have just now discussed. And talking to other factors we should not be doing for which there is no evidence, like rest dietary supplements do not prevent preeclampsia. There's a thing that, okay, your BP is raised, you can take rest. In fact, we should think many times before we advise rest to any pregnant woman. Yes, calcium supplement in women who have dietary deficiency halves the incidence. And the recent WHO guidelines on high-risk pregnancy does say that people in poor resource countries, they should get good doses of calcium supplement right from the beginning. So this is just a summary of my talk about how to screen and how to prevent. So this is once again a request for the chairperson, which I'm going this year. And thank you very much for giving me this opportunity and listening to me. Thank you.
Madhu, you're muted, Madhu.
Oh, I'm so sorry, ma'am. Thank you so much for the lovely talk, ma'am. That was a crisp and clear talk covering all the aspects. Jyoti, ma'am, your expert comments, ma'am.
I think it's very beautifully covered, and there is nothing much to add to it. Let's proceed to the next topic.
Yes, ma'am. Yes, ma'am. Namrata, ma'am. Meenakshi, ma'am said she's not there. Namrata, ma'am, I think she's not yet joined. Okay. So moving on to the next session, we have a very interesting panel discussion on PPH. And for that, we have a moderator, Dr. Priya Kanappan, who's a senior consultant at Mehta's Hospital and Fertility Center at Chennai. And she's also the executive committee member of OXY and co-chairperson of OXY Quiz and Clinical Research Committee.
Thank you, Madhu.
Yeah. Next, can I have this? And we have Dr. Meenakshi Sood. Unfortunately, she couldn't join us today. She's from Aligarh. Next. Dr. Namrata Bhardwaj. Dr. Surumbul Naim from Aligarh Society.
Thank you.
Yes, ma'am. Welcome, ma'am. We have Dr. Ruby Reja, who's a consultant at Sagar, and who's also the secretary of Sagar Obstetric and Gynecological Society. And she's a past president of Sagar Society. Dr. Renu Bansal from Hapur Society. And Dr. Rajshri from Darbhanga Society. Dr. Sri Pritika from Kanjipuram Obstetric and Gynecological Society. Dr. Vidya Chaya, who's also from Kanjipuram Obstetric and Gynecological Society. Dr. Sheikh Shahid Hussaina, who's from Savita Medical College from Chennai. Dr. Nazia Shaikh, who's currently working at Sri Muthukumaran Medical College, Chennai. Welcome, everyone. Priya ma'am, you can start sharing your slides.
If you have any doubts in Dr. Poonam's talk, you can put in the chat box.
Sorry, I
Yes,
didn't
Priya,
come
you can start.
Thank you. To beautify my slides, so we will yes. Welcome to all my panelists. It's such a lovely opportunity which I'm being getting. I don't have anything typed or written here. So, you are going to enlighten us with the information, which is day-to-day practice, day-to-day practical points. So there is nothing special which we are going to discuss outside the textbook. We are not going to take anything. We are going to talk like if a patient has that in your hospital, what are we going to do? Okay, so with that, we are going to just start with the panel. So we all know that PPH remains the leading cause of maternal mortality. In spite of all these protocols, whatever we do, still the PPH remains the leading cause in India. In abroad, the leading cause has been shifted to cardiac disease and hypertension, but still we have PPH still standing there. So we still have some practical challenges. There are few gray zones which are not very clear at that. And whenever there is a consultant level discussion making is there, then you have a problem. Okay, so my agenda for this will be to discuss about the BPH and what are the prevention things and how to go, when is to rightly discuss, recognize, and how to escalate the major issues there. So fine, before going into these details, so can anyone enlighten what is the recent definition for PPH as per the emotive trial? The previous definitions, anybody can tell? We used to teach that for the PGs.
Previously, it was blood loss more than 500 ml after normal delivery and more than 1000 after cesarean. But the new definition is blood loss more than 300 ml with warning signs like atonic uterus, heavy blood loss, large clots, or change in vital sign, or blood loss more than 500 ml even if women have no other concerning sign. This is latest definition.
I mean, the emotive, they say you have to have a alert line at 300 itself. So you need not wait till she bleeds to 500 to go and start off with the treatment. Be alert at that. And it is 500 ml irrespective of whether it is normal delivery or cesarean. So there is no difference between cesarean section. Previously, we used to say 1000 ml for section. It is not there. And again, it depends upon your hemodynamically stable. If a patient is already anemic, so for her, definitely you have to act at 300 itself. So let me go with that with my case. A patient, a 28-year-old, a gravid 2, now she's delivered and she had a sudden heavy bleeding. The uterus is feeling atonic and the estimated blood loss is around 1000 ml in 10 minutes. So how do you estimate the blood loss? Can someone pick up this question, ma'am? Estimation of blood loss, like visual estimation is there. Then we have special drapes. So how do you do it in your practice? What do you do it in your clinical practice?
Ma'am, most of the time the problem is because of underestimation of the blood loss. So it is better we estimate the blood loss clearly and we start an early aggressive treatment. So before the patient goes into shock, we have to give an aggressive treatment. That itself will prevent the death in most of the PPH. So we use calibrated drapes in our hospital, ma'am. Even in government setup, they are now providing calibrated drapes so that the blood loss can be clearly estimated.
Okay, fine. Okay. So yes, I mean, if the calibrated drapes are available, yes. So for people who don't have the calibrated, any other method anybody else is using, madam, Jyoti, madam, you want to take up this question?
Yeah, I think the clinical presentation of the patient matters a lot. Tachycardia is the first warning sign which should be noted. And other than that, fall in blood pressure should also be addressed very early.
Yes, ma'am. So now we have a recent collaboration between the heart rate and the BP. Can somebody just spread out a few words on shock?
Shock index is heart rate upon systolic blood pressure, and it is most of the time 0.5 to 0.7. But if it is more than 1, so that means the condition is not good and we have to act fast. Most of the time we are visual blood loss estimation is not very accurate. Nowadays, we follow the rule of 30. There is a 30, like heart rate increases by 30, or there is a fall in blood pressure by 30, and their respiratory rate is more than 30. Like this, we have to follow.
Yes. So, and your urine output again, which is
Yeah,
30.
if it is
It's
less
going
than
less
30
than
ml
30
per
in an
hour.
hour.
Yeah.
So that is the rule of 30. And
Yeah.
now that, like now we are in the field of litigation. So you have to have a documented evidence saying that your patient is all right. So now the shock index will be a documented evidence for us. Yes. So now the patient, we know she has bled 1000 ml. She has had quite a significant amount of PPH. So when will you say that she had a severe PPH? And when will you start off with the active protocol?
We start from the active. We start active protocol first. Hello. Active protocol in which we assess the patient BP, pulse, and also we apply 2 cannula in both hand.
Yes.
Both hand, and we
First
give.
start with assessment, madam. Then we will go to treatment. So first, what are the things we'll assess? Then we will go to the next slide. Yes. So yes, pulse, BP, I agree. Anything else you want to assess?
Uterine tone.
Is also assess respiratory rate, urine output.
Yes. So the moment we see a PPH, we are going to put a catheter. So we are going to have a urine output. Is there anything specially about catheter you are going to instruct your staff nurse, ma'am?
Bladder emptying is very important because it interferes with uterine contractions. So it is very important step.
Okay. So I completely agree with you. A bladder emptying is very important. Sorry?
We'll also see like whether patient is anxious, confusion, any like GCS also we'll see.
Yes, very important. Sometime when your patient is having air hunger or if she's breathing, like, she's having that acidotic breath, we know that the patient is already gone into shock. Yes, ma'am. Completely agree. So you have to assess the patient. Yes, ma'am. Yes.
Oxygen is also 8 liter per minute.
Yes. So, yes. So we give her the oxygen. We check for the saturation. If you have a specialty of monitoring, you yes, you will check the availability of blood. Yes. So now you can go around with your immediate resuscitative measures, madam. So what are the things which we are going to do for resuscitation?
First of all, we
usually yes, ma'am.
Okay. You just take it.
Usually we put 2 large cannulas that, and immediately you can take blood for grouping, cross matching, and then actually tranexamic acid works very well. You immediately give 1 gram tranexamic acid, and also check the coagulability of the whether the PT, APTT, how is the APT, APTT of the patient.
Yes.
And at the same time, we can start giving utrotonics. No, we can. You have to assess whether it is only atonic PPH or any traumatic PPH.
Yes. So, like,
and also you should
we have to
rule out
identify the
retained
cause.
placental bits also, ma'am.
Yes. So
I want to add something.
then by the time you're going to assess what is the cause for the PPH. So can someone talk about the 4 T's, madam? We teach the postgraduate. We are so used to hearing 4 T's. Can one of you tell me what is the 4 T's?
Tone, tissue, trauma, and thrombin.
Ma'am, tone accounts for 70% of the cases and tissue accounts for 20%. Then trauma accounts for 10% and coagulation factor accounts for 1% of the cases.
Yes, so
the
most
least common cause.
Tone, but we should always keep the other things in mind as well. So if the tone is good, then we go ahead and evaluate the other reasons. Yes, ma'am. So, and about this one. So, like, there is a controversy nowadays whether to give IV fluid or not to give IV fluid. Can anyone take up this question? Like, are we supposed to give this 2 liters of crystalloids followed by 1.5 liters of colloids before the blood comes? Should we get the blood and give it? And why is there a controversy there?
See, sometimes it is better we give. Yes. sometimes patient can go
Yes,
for
if you don't
pulmonary
have a blood,
edema.
we are. Yes.
So better
And there
you
is one
assess the
thing
blood
which is,
loss
yes.
and then give the. You need not rush the fluids. You can, if your vitals are maintaining, even if it is 90, 60, it is maintaining, tachycardia is just little bit, it is raising. I think there's no need to panic and rush fluids inside.
Yes.
Unless you
There's
see a
one
very
thing is like,
IV fluid, IV fluid is
fluid.
mainly for prevention of shock, ma'am. Before the blood arrives, it is better we stabilize them and we prevent them going into shock.
Only for
So it is always
stabilization.
better you,
Yes, it always depends upon what your vitals are telling you. If your vitals are showing your patient is going in for shock, yes, you're going to rush in fluid. We all agree with that. I don't think anybody is
correct.
not.
Yeah.
Yes, I agree with it. Your patient is hemodynamically stable. What is the controversy here is that when we give IV fluids, okay, we are making a dilution there, and whatever coagulopathy or whatever the coagulation factor which is already available, they become dilute and they prevent them from further clotting and the PPH occurs. So that is the controversy now. So they say if you really have a patient in shock, then give the fluid. Otherwise, you try to get the blood or the blood products. So that is what we are there. So can someone tell me a little bit more about tranexamic acid? Like how many doses or till how many hours you started its of use?
Tranexamic
acid. Yes, ma'am.
Yes, ma'am.
Tranexamic acid 1 gram should be given in 200 ml and it has to be given over 10 minutes. And it is better you give it within 3 hours. I mean, first, only if it will act immediately. After that, it will not have any action. And if needed, you can have a second repeat dose alone.
Okay. So how much hour, how much time we will repeat the second dose?
30 minutes.
30 minutes. So completely agree. It doesn't act if you give it after 3 hours. So if at all you are planning to give it as soon as possible. Give it within 3 hours. And if at all you're repeat it in half an hour. That is one. Second thing is like initially the RCOG came up with the suggestion saying that for elective LSCS, if you give a tranexamic acid preoperatively, it prevents PPH. Now they have withdrawn the statement telling that it is no more useful. Don't give tranexamic acid routinely before PPH. So that is gone nowadays. Like that came 1 or 2 years back where everybody were pushing in tranexamic acid like one, GEMS packet. We just give it and we just pull to every patient we were giving. And now they have themselves withdrawn saying that only needed patient you give. So we will go this we have already covered there. So what is the sequence of uterotonic in your real practice? We all know oxytocin you can give up to 40, 50, then methergin up to 5 doses. Carboprost up to 8 doses, mesoprost up to 1,000. So you tell me, how much do you really give in your practice before you shifting to the next line?
The oxytocin given 10 international unit.
IM, that is for active management.
For lactic acid, we give it 20 unit.
Okay, so you are adding 20 unit in drip.
Unit in 500 ml of the NS or RN.
Yes.
And then we may be, and if there is not, and in the 2 to 3 hours. If needs, then again we give the next bottle also, 20 minutes. And
okay,
again,
so you give first 20 units. Yes, yes, Vidya, yes.
20 minutes.
Yes, no, we also give
even
you
to
let Madam finish. Yes, ma'am.
Maximum dose is, ma'am, 60 international unit.
Okay, so we give a
And
per
what
day.
we practically do.
Yes.
Yes, ma'am. Practically, despite speaking all these theory aspects, practically what we do is we start 20 units in 500 ml oxytocin, and simultaneously we do give carboprost 250 microgram IM, and we keep 1,000 micrograms of misoprostol per rectally, and we will watch if the bleeding is getting controlled. If not, might be after 15 minutes we repeat a second dose of carboprost. But with that, if it is not getting controlled, probably we go for the other methods. We go for most of the times we are using SR cannula, which works out really well. We have
Okay, let us not go
saved so many patients.
Finish up my history. Panel gets over. Wait, Dr. Spritika, we are not finishing the panel with one question. So we are only
No. Practically, how many doses you ask? No, ma'am. That's what I'm telling. So before shifting to the other treatment, I'm talking about
now. We are coming to SR now. You are telling, yes, I agree with you. If there's anything anybody else wants to add, Vidya, you were starting. So Vidya, can you tell me
No,
what you want to add?
we usually we usually give like 20 to sometimes after giving the active management of third stage of labor, 20 to in fact up to 40 minutes we put it in the drip over 3 to 5 hours also slowly. And we prefer to go for ergometrin if there is no contraindication, because in our practice we see that it works so well immediately. The contraction is very good, effective. And we always put prophylactic misoprostol. Sometimes even through the cervix, we insert or during the surgeries itself, we insert it through the cervix, 800 or 1000 micrograms of misoprostol. That works well, actually.
Okay, so I agree with it. Now, like we will anyway, we see a patient, we always insert a misoprostol in the per rectum. There is no doubt there. Yes, oxytocin, we all agreed with it. Like, yes, you all choose carboprost. Is there anywhere you don't want to give carboprost? Any specific contraindications?
Asthmatic, we
Asthma
don't
for
give.
carboprost.
As we all know,
Asthmatic.
Asthma, not
Asthmatic.
give. Yes,
asthmatic.
and anything else? Yes,
Asthmatic and
any other contraindication?
an allergy
Asthmatic
to
and?
cardiac disease, severe
Okay, fine.
cardiac, also sensitive
Yes,
to
cardiac
the
disease, we are not giving, madam. Okay. And no one was choosing methergin. Nobody uses at all.
No, we are using.
Nobody
We are
chose
using
Using it
methoxin
works
when,
well. You
there in
cannot
the
say that,
starter.
when
and it is
oxytocin
a
is not
one-time drug
working, then we use
actually.
methoxin. Because
Yes,
oxytocin
so
works on upper
No,
uterine
we
segment and methoxin works on lower uterine segment. So it works beautifully after oxytocin.
lovely. So if your oxytocin is not
yes,
work, few
yes,
of us are agreeing. Yes. How are we going to give
we go
methergin?
for methergin.
I am.
If the anesthetist is there, actually it is given under IV, slow IV. Over 3 minutes, it is given slowly.
Okay, so it again depends upon
Because
the anesthetist
yes,
there. So some people are little
yes,
worried
yes.
really to give IV.
Then they give
Most of us are
Adram also,
comfortable giving
intramuscular
IM.
also. Yes,
Yes.
yes, yes.
So, like, can someone take up the question and tell why are most of the people scared of it? Why are we not taking? Because when we were PGs, after oxytocin, now it is.
See, methergin has to be used with caution in cases of heart disease and also in cases of preeclampsia and eclampsia. And if the patient is in cardiac failure, CCF due to severe anemia, then also we have to be very cautious. And so similarly, with overloading the patient, we have to keep in mind if she is in failure, then we have to restrict we cannot use the drugs very rampantly. Then we
So
have
you
to
will
make a
assess
clinical
the cardiac
decision.
status because your PPH can per se cause a cardiac disease there. So you assess your patient and then decide on message. Completely agreed, madam. So we will go on with the next slide. So this is second gravida, previous LSES planned for elective LSES. In the LSES, there was a
No slide is moving.
ml. Slide not visible, madam. Me to see. Slide
Yeah,
is not
ma'am,
visible to
visible,
everybody.
madam. But Priya, ma'am, your voice is breaking, ma'am.
Yes.
Sorry, my network is poor and I'll come out for that. My previous planned session. Okay, hear me now, ma'am. Hello. Hello, can you hear now, ma'am? Hello.
Yes, ma'am. Yes, ma'am.
Yes.
Give stress fracture in the uterus.
Sorry.
There
No,
is a uterine atony. In this case, there is a uterine atony. So you give.
There is a uterine atony. Yes, madam. So my question here is, we have discussed about how to manage a uterine atony. Completely agree with last whatever we have discussed. Is the management different in a patient with cesarean compared to a person who had a normal delivery? That is my question to the panel. So now, till now, we discussed in detail about everything. Like we told about oxytocin, methergin, carboprost, misoprostol. Agree with everybody. Tranexamic acid, all we are going to give. We are not defying at all. Is the management any different in a case of cesarean or is it the same?
Yes, this is a different because there is a surgical management is necessary because the uterus is atony and large, flappy, maybe flappy.
Yes.
So we must be either uterine artery, ovarian artery ligation, square suture, and later
Compression sutures.
compression suture, and later on, if they know, then the internal iliac ligation.
Got it, madam. So in a case of cesarean, because we already have an open wound there, we don't wait for that long to the drugs to act. You know, once the drugs are not acting, you will shift to a surgical management a little early compared to a vaginal delivery. So my panelists agree with me. Can we go to the next slide, ma'am?
Yes,
Yes.
ma'am.
Yes.
Totally
So
agree.
now the uterines, this one, like I want each one's experience. What are your sequence of events? Like, everybody will agree with uterine massage for a normal delivery. Anybody does that for cesarean also?
Yes, I
Yes.
do.
Yes.
Yes.
Yes,
Cesarean
ma'am, we
technique
do,
also?
ma'am.
So is it
Yes.
like, should you keep the uterus
Yes, yes,
outside
yes.
and massage, or put it inside and massage the skin? Which works better?
Inside and
Inside the
massage.
massage is
Works
also
The
good,
better.
ma'am.
uterus outside
Inside
is much better
Okay. So you can
I also
either,
feel it. Keep it
because
outside and
uterine
massage, ma'am.
arteries
And our anesthetist recommend giving intramural carbopress, ma'am, in a cesarean
that
section.
is, I'll tell you, no, that is again depends upon the anesthetist. There are very few people. I had one anesthetist who even give misoprostol inside the uterus. But there are very, very few of them. So let us not come and recommend that as a practice point, because none of our guidelines are going to tell that. That is the anesthetic's perspective there. So yes, we are going to give medical management, and then yes. So now the choice between compression suture, uterine artery ligation. So these two first let us take. What will you choose the first one? Whether is it compression sutures or is it uterine artery ligations?
Ma'am, if it is going to be a bleed from the vessels, then if it is going to be a lower segment bleed, then we'll go for uterine artery ligation. If it is going to be atonic, it is better to go for compression sutures.
Okay, got it. So anybody differs in this point, or we agree with this point?
Yes.
Yes, so
correct.
know that it is a uterine atony, we give a compression sutures. So anybody has heard of some compression test or something which people used to do? Initially, we used to teach our postgraduates. Anybody do that?
Bilateral compress.
Suture, both are important.
Yes. So compression test is nothing. You just try to hold the uterus, compress, and see whether that compression is reducing your bleeding. And if it is going to reduce, then you know that your compression sutures are going to work better. Usually, before we put, we try to do that. What material you use and what type of sutures you put for a LSCS. Compression suture.
Catgut is used for the compression suture.
What catgut, madam? What number?
Chromic number 1 catgut.
Okay, chromic number 1. Anybody, any other material you use?
Vicryl.
Yes, because in many centers, chromic
Vicryl can
is
be
not
used.
available.
Vicryl is very
What
important.
number?
Vicryl we can use.
Vicryl number 1. Vicryl number 1.
Vicryl number 1. So what type
One
are you
number.
going to give? Is it a B-Lynch or a Heyman?
B-Lynch.
We prefer using Heymans, ma'am.
Heyman. So it is depending upon your own convenience. Like some people, if your LSCS wound is still open, then you can easily do a B-Lynch. If your LSCS wound you have closed, you can even still do a Heyman. So that is what we are doing there. Fine. So when will you think of putting a balloon tamponade in a patient with cesarean session? Putting a balloon and coming out. Okay, I'll put just a balloon and I'm going to come out.
No.
In the vaginal delivery, we like to do in the case of the vaginal delivery, we like to give the balloon tamponades for
Yes.
24.
Yes. So, and suppose if you have a lower segment bleed at home, for
Yes, ma'am.
example,
For
like
lower segment bleed, we prefer giving a balloon tamponade.
In a
Then
cesarean
also we would not like to leave and come, right? Unless
No, if
say
you're
when
very
you are in
sure
lower
that only
segment
your
We
and
lower
combine with an uterine artery ligation, ma'am.
No,
We
if
do a
you are
uterine artery ligation
better
also.
with
Then we keep a tamponade.
yes, but if it is a lower segment, it is only a trickle. Then you try to put a balloon and come out. But it's not for a massive pouring bleed. We are not talking. If it is just a trickle, you want to give a balloon. So that is where you are going to choose. And LSCS, if it's for vaginal delivery, we are choosing a balloon. Balloon versus SR, depending on what is your convenience. Yes. So which balloon are we using? So each one, what are the balloons you have used? Balloon catheters, what are the balloons which have been used, madam? Like, in your experience.
Be balloon and condom.
Condom
Either
catheter, yes.
or Bactri balloon.
Or condom. Yes, madam. Anybody else is using any of these expensive balloons?
No, ma'am. We also use Foley or the condom. Sometimes we do put 2 Foleys.
Okay, fine. So, yeah, there are people who put, and how much ml, how big is the Foley's catheter, distended?
30 to 60 ml.
30
Usually 300 to around
200.
Foley will not bear 300 ml, pa. Foley.
Oh,
40 to 50 ml.
40 ml, okay.
yeah,
Sometimes
balloon.
Balloon, I agree. 300 to 500 ml. If it is a condom
Yes.
catheter,
500
if you
ml.
have
Yes.
a very good setup
Yes.
of like a very well equipped setup, they will give you any balloon. Okay, a very good paying patient. What balloon you want to try?
Bhakri balloon.
Excellent, madam. Thank you. So
But
if
now I have to say one more thing. See, we are
Yes, ma'am.
using balloon tamponade in our cases where the patient is being shifted from a PHC or a CHC to a district hospital or medical college. So while transport, it's a very good method. When the patient has delivered vaginally and there is no scope for surgery there, and maybe further management is required, surgical management, then the patient can be transferred on a balloon tamponade.
Sure, ma'am. Got it. So while shifting, yes, similar to your non-pneumatic compression stockings,
Sure.
compression dressing, like same,
Compression
it's going to
stocking
do that.
also.
Yes,
Yeah.
lovely. So again, now SR cannula, it was a previous slide which was not there. Now there are loads of people using SR cannula. So do you routinely use it? There are people who use it as prophylaxis. Is any of my panelists using SR as a prophylaxis? If you have a high risk patient, for example, over-distended uterus, twin pregnancy with the with polyhydramnios, a big baby. Anybody want to use SR as a prophylactic?
no.
No.
No, we are not
Okay,
using.
so that is the take home we want to give. If you don't have a PPH, don't use anything. If you develop, then we can use that. So what is your experience? Like how long you are given the SR cannula? What is your break time? And how long we can maintain? Can any of you, whoever has tried SR, can you just give your own experience, ma'am? Anyone with SR cannula experience?
Yes, ma'am. We do use SR cannula routinely. For high risk cases, when we don't have control of dealing with the medical management, we go for the SR cannula. What
Yes.
we try to do is we insert the cannula and we give the negative pressure for 15 minutes. And
Yes.
when the bleeding stops, we just connect it to the suction tube and we just clamp it and keep. If the if there is more amount of collection, we again give the pressure after 30 minutes for again 15 minutes. And with that itself, in most of the cases, we have very good control. And I even presented a paper on that. Only one case we had more amount of collection, more than 500 ml, which we had to take up for surgery. All other cases, we had excellent control with SR cannula, and even the blood transfusion was minimized, ma'am.
Yes, very nice. So, like, what is
And
the
we remove it after 24 hours, ma'am.
Oh, you leave the catheter. So the patient will
Yeah,
not be
if it comes out, no,
24 hours.
ma'am. We just clamp it and keep. And in most of the cases, if there is good blood control, then it will automatically come out. And if not, we will try to remove it only after 24 hours.
Okay, fine. So, like, is there any other, like, complications which you are treating? Why are we not preferring a SR cannula nowadays?
If we don't properly place it, the vaginal tissue also gets sucked in, ma'am. So that is a problem. So if
That's
we
one.
properly place it with the gauze piece around, we don't have that complication.
Okay. Anything else anybody else can think of? SR cannula? Many centers have not been preferred it. Yes, Dr. Ruby, you want to take up?
No, ma'am, I am not using this cannula.
See,
So
the
no
one
support.
thing
I'm
about
not using.
SR cannula is that we don't have large quality studies, okay? We don't have large volume studies. And though they say we have had the second patient with us delivered, they don't have a complication, we don't know the effect of endometritis, subclinical endometritis causing infertility and all these problems. We don't have studies. When you have studies, we can always recommend. We still are waiting for the studies to come. That is one point. Second point is if you leave the SR cannula for quite some time along with the suction connected, then you have a difficulty to remove that. The tissues get stuck there, and then you go and do a lot of manipulation, and then you deliver it. That is the only difficulty which you're saying. Fine. So internal iliac ligation. So do we do the internal iliac ligation, or do we call the urologist or the oncosurgeons?
It's better to call surgeon.
Okay. Anybody else differs in that?
Ma'am, in emergency situations, we can't get urologists all the time, ma'am. So we are trained to do and we will do, ma'am.
So you are doing, Pritika? You are doing it?
Yes, ma'am. Yes, ma'am. In emergencies, we do ourselves, ma'am. In elective cases, if we are planning for a placenta accreta, maybe on-call urologist will be available. But in case of an emergency at midnight, we do, ma'am.
Okay, got it. So anybody else are doing, ma'am? So any tips you want to
We
tell us?
call surgeons only most of the time.
Okay, yeah. And definitely in that panicky, that tension, whether, and it's not a day to day, we don't do it every day. So one thing people are saying is that just practice on your normal patient so that you get used to, you are ready for the emergency. That is one. So Sri Pritika, you want to give us some tip on internal iliac ligation? Something, one tip for a consultant, practicing
But
consultant.
like you told, all will have a panicky mindset at that time. So if I'm doing the case, then I will call some other person to do. But if somebody is calling me, I will be very confident and will go and do. Because when you stand on this side, your mentality will be different.
Yes.
Yes, ma'am.
So
So
what
we have
approach
been,
do?
and we go through the round ligament. If you
Okay.
go through the lateral half of the round ligament, it will directly go on to that side. And we are trained to do that. So we just do the dissection from the lateral side. And we see to that we identify the uterine posterior division and we just go 2 centimeter below and we tie it up, ma'am. We
Okay.
just, we do only a ligation. We don't cut it in between.
Okay, yes. Can anybody else, tell me why are we just doing a ligation and not cutting the internal iliac ligation? I mean, internal iliac, why we are not cutting? Only ligation is due. No, that is what is to be done. You cannot cut the internal iliac. So what is the principle of internal iliac ligation? Principle of
Actually, when a surgeon or a urologist does, they actually cut it.
we are not
But
supposed to, that is why we are not supposed to give it to them because they don't know the concept there.
we do it because there is a plenty of collateral circulation. So no, naturally there will be re-establishment. So that is why we do the ligation.
Anyway, we really don't know whether are we going to get some fertility issues after that. So that is the thing which we are worried about. The one thing is that it brings your arterial circulation into a venous circulation. It reduces your pulse pressure. So thereby you don't need a further management, and it really works for that. Okay. So now my second case, a second gravida, previous 1 LSCS, a low-lying placenta. She is bleeding from the lower uterine segment. So when will you decide whether it's conservative or you will plan a surgery? Like surgery means putting a stitch there, or whether you will go and escalate on the steps which we have explained till now.
The case of the low-lying placenta.
Yes.
So so we give the stay suture in the lower segment of the cervix also, because there is a raw area in the cervix that is not contract properly as the upper segment. So we do the uterine artery ligation and also give the stay suture in the lower part of the cervix after the separation of the bladder.
Okay.
Yes.
So now we know a patient, the second, third gravida, previous 2 cesareans, placenta.
Ma'am, your voice is breaking and you're stuck, ma'am.
Ma'am, can you hear me?
Yes,
Do the conservative management also in the case of the PAS syndrome.
Yes.
You give the tourniquet by the Foley's catheter at the below the level at the level of the uterine artery. So first you tight the first you deliver the baby, and simultaneously we tight the at the level of the internal os.
Okay.
And then we preserved the uterus after the removal of the some part of the placenta, and rest part of the placenta may be leave and give other medicine to dissolve the part of the placenta.
So do all my panelists agree with that? Previously antenatally diagnosed placenta accreta syndrome, you go inside and you're sure that the placenta accreta is still there. Okay, is there anything you decide, or to this level I will attempt, this level I will leave, or I will not touch the placenta, leave it behind and go ahead with surgery? So can one of, each one of you just give it very short. Okay, what will you do?
In previous 2 LSAs with the PAS, we plan an elective procedure along with the urologist and we do a in situ hysterectomy.
Okay, so you are going to do an hysterectomy. Anybody else, madam? Dr. Ruby, madam, what are you going to do?
If it is PAS, then definitely hysterectomy.
Okay, Jyoti, ma'am?
If there is an interventional radiologist who can do a uterine artery embolization, we could give it a shot. But then planned hysterectomy is a better idea, in my opinion.
So
It
yes,
works
you
always.
can give the, I mean, this one interventional radiology, put a balloon, put an embolization, and we explain to the patient. We will try to leave behind the placenta and come. We'll give you some drugs and see. If it is not going to work up, we'll we'll need another interventional surgery if at all. So that is the plan. Is anybody else doing anything different, or we'll go to the next?
Next.
So now coming to a PPH in a low resource setting, a rural hospital where there is no blood bank, severe atonic PPH. Now I think most of the resident doctors will be encountering this situation because after the postings, they have been compulsorily doing a bond in the rural hospital where they don't have facilities. So as a seniors, I want you to give one advice or whatever the tips for managing.
Active management of third stage of labor.
Yes.
First.
Or if
Active
severe,
management of third stage. Yes.
severe atonic
Maybe
PPH,
like high-risk patients, they better refer earlier.
Before
They
that.
have
Before
and
Good
they have to
manage
refer with an NASG
high-risk
suit,
patient.
ma'am. They have to refer with an
NA,
NASG
yes,
suit.
yes.
Everybody should be trained in applying an NASG suit. So they
Okay.
have to stabilize and refer as early as
Available?
possible, and they should know the
Yes.
management with all the basic uterotonics.
Okay, got it. So basic management, everybody should know. And when you feel that you cannot manage, try to refer them a little earlier rather than referring them in shock. So, and then NASG tool is good. And if you have a balloon tamponade or this one, as madam has already told, you can put that and send so that you know that the bleeding will not be that very heavy. So is there any other tips anybody wants to say if the patient is been in a rural setup?
Prophylactic oxytocin is must be given, and we also use the mesoprost vaginally before we transferring the
At least give the basic oxytocin before trying to shift the patient. Don't just shift it, telling that place will manage. You give the medical management and then shift the patient. So got it, madam. So now, I mean, in your practice, of these, in your experience, which has been the most effective lifestyle intervention? We have spoken about all these things, the UBT, SR cannula, iliac ligation, and hysterectomies. So of these, in your practice, which has been the best?
SR cannula.
So SR cannula works, yes. Then?
Yes. And if there is in last there is no any chance, then hysterectomy is a choice.
Yes. So if there is a chance, if you feel that there is a much of bleeding and you feel it's really you're going to lose the women there, it's okay to lose the uterus rather than wait for too long. So that will be the take home for that. So everybody, we want to save the uterus. I agree with it. But saving the uterus at the cost of the women's life is not going to be worth it. So you will decide early rather than when a patient is gone into irreplaceable shock or irreversible shock, even a hysterectomy will not help that time. So don't decide on hysterectomy later. So, and I think this is there. And are we teaching the skill adequately? So for people who have been there as postgraduate teachers, so this is the question to you. Are we teaching internal iliac ligation for our postgraduates? Whether if they have a PPH, can they do an internal iliac ligation on themselves? So what is your take on that? Should we start teaching?
Yes,
we must
definitely. We must.
Yes.
train the
So
P
that
to
will be one of the.
you
Yes, ma'am.
must train the my PG to the iliac artery ligation.
Yes.
Because this is the life-saving
Yes, ma'am.
procedure.
So you will it is better that we start training our postgraduates so that they are ready for any PPH, especially when they are practicing in a setup where the blood banks are not available. So are we trying to save the uterus? So, what is the controversy or in which patient should we waste time or should we think about saving the uterus?
If there is a severe, as like there is when we do the emergency cesarean or there is a pass syndrome and bleeding is not controlled, then we like to do the early decision for the hysterectomy.
Yes, ma'am. So depending on first is the clinical scenario. If a patient is having a high risk to bleed and you know that she's going to continuously bleed, you're going to definitely decide on cesarean section. Decide on hysterectomy. Yes, that is agree. In a young patient, we try to conserve. If it is a life-threatening, we are not going to waste that and trying to do the hysterectomy in a time before the shock is always advisable. So do you think India, are we delaying hysterectomy too much? I don't. Ma'am Jyoti ma'am, you said yes. You
So
think
me
are
as
we delaying hysterectomy?
Yes, many a times we do delay.
Okay.
the
So
emergency.
actually, in
And
patients who we are lost. Yes, yes, Vidya. Yes.
no, sometimes no, we think we can get controlled it with medications, and we little bit be on the conservative side. It is that time maybe we are losing the patient.
Yes. So for people who have gone into these maternal mortality meets and other thing, most of the decisions would have been that they delayed for quite some time and the patient is already gone in for DIC. Though the decision for hysterectomy was taken, it was too late, and by the time they could not save the patient. So the one take home point from here is that if at all your bleeding is not getting controlled, take a decision before the patient goes in for irreversible shock or DIC. I think we come to the end of my panel discussion. So thank you everyone, and thank you Dr. Sambat Kumari madam for the wonderful opportunity. And if there is any take home point you want to give the youngsters and the colleagues, kindly be free to share, ma'am.
Okay, Dr. Priya.
Thank you, Priya. Thank you, Sambat Kumari ma'am, for
Can I
giving
say
this
something, madam?
opportunity.
Dr. Nandini,
Thank
can
you,
I speak, madam?
Yes, ma'am. Yes.
May I speak, madam?
Yes,
This is
Usaina.
Dr.
Yes,
Namrata.
ma'am.
Yes, Dr.
ma'am.
Priyal, I must congratulate you for an extremely clinical-oriented panel discussion, and your panelists were just wonderful out of the world.
Thank you.
I would just like to salute your panel. I was just thinking, I think we are paying too much attention to the newer concepts of PPH. We should, in fact, be focusing a lot on what is the third stage. Number one, our time and test. Mostly, I would like every hospital and every clinical setup to have a regular PPH drill with whoever you are working with, because that is life saving, and we will might not be requiring your balloons and your hysterectomies and your artery ligations if we have proper PPH drills. Yes, you're very right. We should not delay hysterectomies at the cost of the life of the mother. We should be very proactive as far as management of PPS is concerned. And the other point that I want to highlight, you have already touched upon it. Always ask for help if your patient is deteriorating. Because obviously the person who has been working with the patient is always anxious. The doctor is always anxious. It is always better to have a second hand, a second mind, and a second person who comes with a better service. And I think you've touched everything very beautifully, and your panelists were just wonderful. I loved the insights that they gave. Thank you very much. Dr. Sampath, madam, thank you very much for including me in your webinar, madam.
Thank you, ma'am.
Thank you.
One is
Thank you
call
so
for
much,
help. You have beautifully
madam.
told that. The second one is always document. You could have done extremely well, saved the patient or lost the patient. That does not matter. If you have not documented, it means you have not done it. You are not safe without documentation.
Priya.
Thank you so much, Priya ma'am.
Priya and Madhumita, please tell
Yes.
that vote election.
Yes, ma'am. Yes, ma'am. Sathi, can you please share ma'am's flyer, please?
Sagiti will not be having only Chitra. You please inform, that's all.
Yes, ma'am. So a humble request. Sampath ma'am is standing for the President Foxy 20, and the election is in August 2026. So humble request to everyone to please support and vote.
Yeah, please,
and
everybody
please share in your societies also. Thank you so much,
after a
everyone.
long time, somebody
Yes.
from South standing.
Don't.
So kindly support
Oh.
madam. Madam has been our president of Oxy.
Yes.
So yeah, like you all know, madam, she has been the chairperson of the adolescent committee. She has been the vice president of the South Zone, and now madam is climbing up. We really want madam to go to heights, so that we can also be proud to say that yes, from a woman from South has been representing Foxy there. So it's a proud moment for us. Kindly support madam in our upcoming elections. It's in the August of 2026. Kindly support.
Yeah.
Thank you, Priya. Thank you, Madhumita. Thank you, all the
Yes, ma'am.
delegates and faculties. Thank
Yes,
you,
ma'am.
madam. All of
Thank
you.
you, ma'am.
Thank you.
Thank you very much.
Thank you, ma'am.
Professor
Thank you, ma'am.
Sampath.
Coming to the end of
Madam,
the